Welcome to the deep dive. Today we're tackling a really significant area in vascular surgery, the treatment of aneurysms affecting the descending thoracic aorta, and especially those that involve both the chest and the abdomen, what we call thoracoabdominal aortic aneurysms, or TAAAs.
Yeah, exactly. And this is a field where the surgery is incredibly demanding, technically speaking.
Right, and it puts a huge amount of physiological stress on the patient.
That's right. Despite all the progress in medicine, operating on these types of aneurysms, it really remains a major challenge.
So our goal with this deep dive is to really get under the hood, understand the open surgical approach.
Exactly. We'll be looking at the medical literature, seeing how surgeons have tackled these problems, from the really early challenges to the advancements we see today, but always keeping in mind the risks that are still involved.
And for you, the listener, our aim is to guide you through this pretty complex topic in a way that's, well, clear and informative. We know you're looking to gain knowledge efficiently, maybe get those aha moments without getting totally bogged down in the jargon.
Right. Think of us as guides, cutting through the technical stuff.
We've looked at the literature on open surgical repair to pull out the key insights.
And maybe the best place to start is with a bit of history, just to appreciate the scale of the progress.
Good idea. Where do we begin?
Well, early attempts were, frankly, very risky. For example, back in 1954, Dr. Adams documented a really high risk of paraplegia.
Paralysis.
Yeah, paralysis. Around 25% just for thoracic aortic repair.
Wow, 1 in 4. That's staggering.
It is, and it gets even more sobering. Just about a decade later, the pioneering surgeon, Dr. DeBakey.
DeBakey, yes.
He reported a 50% mortality rate in his initial attempts to repair TAAAs.
Half the patients?
Half. Those early numbers, they really underscored the incredible progress, but also the immense hurdles surgeons faced.
Okay, so to really understand how far we've come, let's start by unpacking the underlying conditions. What actually causes these aneurysms?
Right. Understanding the pathology, the nature of the disease, is absolutely essential. It directly shapes how we approach the surgery.
Makes sense.
We generally categorize these, and the most common type we see are degenerative aneurysms.
Degenerative. Okay, so what's the process there, like wear and tear?
Sort of, yeah. These typically occur in older individuals. They often have atherosclerosis, hardening of the arteries, and often a history of smoking.
Right.
The development involves inflammation within the artery wall, the action of enzymes called matrix metalloproteinases.
The MMPs.
Yeah, those. And they cause a breakdown and remodeling of the collagen that makes up the aorta. So essentially, it's a gradual weakening of the vessel wall.
A gradual weakening.
Precisely. And this process often leads to other complications that make the surgery even more complex.
Like what?
Well, we frequently see calcification, damage to the that's the inner lining, and the buildup of plaque and blood clots. Branch vessels can also get narrowed or blocked off.
That sounds like a surgeon's nightmare.
It certainly adds significant complexity. And to make things even more challenging, these patients often have other health problems.
Pre-existing conditions.
Exactly.
Yeah.
Affecting their heart, lungs, kidneys, which naturally increases the overall risk of any treatment.
Okay.
And there's also a more severe form called an inflammatory aneurysm.
Inflammatory.
Ooh.
That sounds serious.
It is. In these cases, the tissue surrounding the aorta, including vital branch vessels, the ureters.
The tubes from the kidney?
Yeah, those. And even parts of the bowel or chest structures, they become encased in this dense scar tissue, what we call fibrosis.
Wow.
And that makes the surgical dissection and repair exceptionally difficult.
Right. That paints a very clear picture of the difficulties. Okay, what about other causes? You mentioned inheritable pathologies earlier.
Yes, there are genetic conditions that predispose individuals, often younger people, to developing these aneurysms.
Like Marfan syndrome.
Exactly. Marfan, Ehlers-Danlos syndrome, Loeys-Dietz syndrome, those are the well-known ones. They're linked to specific genetic mutations affecting key structural proteins like elastin and collagen, or signaling pathways like TGF-beta.
So it's a fundamental weakness in the building blocks of the aorta, basically.
That's a good way to put it. It's fundamentally different from the degenerative type. And what's becoming clearer is that similar genetic mutations can also account for aneurysms that run in families but don't fit neatly into those syndromes.
Oh, okay.
And even in some people with no clear family history. What's really interesting here is the variability in the aortic tissue quality.
How so?
Well, the tissue the surgeon has to work with can be very different, not just between these conditions, but even within the same condition.
So a Marfan patient might have different tissue fragility than someone with, say, Loeys-Dietz.
Precisely. For instance, patients with Ehlers-Danlos and Loeys-Dietz syndromes often have more fragile aortas compared to those with Marfan syndrome.
And that changes the surgery.
Absolutely. This increased fragility might mean using less traumatic clamps, or maybe even opting for hypothermic circulatory arrest to avoid clamping altogether.
Right.
You might also need to reinforce the suture lines with felt pledgets or strips to stop the fragile tissue from tearing.
Okay.
And unfortunately, in some of the really severe forms of Ehlers-Danlos, surgical repair might not even be a viable option.
That's a sobering thought. You also mentioned trauma, mycotic, and vasculitis-related aneurysms. They sound very different.
They are, and each brings its own unique challenges. Trauma, for instance, often involves multiple injuries, which obviously complicates things.
Sure.
Mycotic aortitis, those are aneurysms caused by infection. They require a very aggressive approach.
Aggressive how?
Radical removal, basically. You have to take out all the infected aortic tissue and the surrounding stuff, then either repair it right there or do a bypass around the infected area.
Radical debridement. Yeah. Sounds extensive.
It is. The text actually shows a figure, 79.2, illustrating just how much aorta might need removing and replacing.
Wow. Okay. And vasculitis.
Yeah, aneurysms linked to vasculitis, inflammatory conditions affecting blood vessels. Things like rheumatoid diseases, Takayasu's arteritis, lupus, giant cell arteritis.
Less common, presumably.
Less common, yes, but they can present with blocked branch vessels, heart and lung involvement, all adding complexity to the repair.
So a really diverse range of underlying issues, each with its own surgical implications. Okay, so once an aneurysm is found, how do doctors classify them? Location and size must be key, right?
Absolutely. Classification is primarily based on how much of the aorta is involved, the extent.
And that tells you about the complexity.
Exactly. Complexity and, importantly, the risk of paralysis. We touched on that high risk early on.
Yeah, that 25% number.
Yes. The Crawford classification is the most common system for the thoracoabdominal ones, the TAAs.
Crawford 1, 2, 3, 4.
Right. Type 1 involves most of the descending thoracic and upper abdominal aorta. Type 4 is mainly the abdominal aorta below the kidneys.
And the risk varies.
Significantly. Type 2, which is the most extensive, basically the whole descending thoracic and abdominal aorta, carries the highest risk of paralysis. Aneurysms just in the distal arch or descending thoracic aorta have the lowest risk.
That makes intuitive sense. The more aorta you replace, the more potential impact on the spinal cord's blood supply.
Precisely.
What about aortic dissections? How do they fit in?
Dissections have their own classifications, like the Stanford system.
Stanford A and B.
Correct. Stanford A involves the ascending aorta that needs immediate surgery. Stanford B starts further down in the descending aorta usually, and historically was often managed medically.
Okay.
But these classifications, while useful, don't capture everything. And generally, repairing dissections carries an increased risk of both stroke and paralysis.
Right. Okay, so we understand the types and classifications. Now, the big question. When do you decide surgery is necessary? It can't be every aneurysm you find.
No, definitely not. The primary driver for recommending surgery is the risk of rupture.
Makes sense.
And generally, that risk correlates with the diameter. Think Laplace's law, bigger aneurysm, thinner wall, higher chance of rupture.
But it's not always straightforward.
Not entirely. You can see some really huge TAAs over 10 centimeters that have surprisingly thick walls and don't rupture. But the risk is still there.
So what's the typical size where rupture becomes a major concern?
Our experience suggests rupture or other acute events like dissection or plaque hemorrhage tend to happen at an average diameter around 8.2 centimeters, though interestingly, only about 13% of ruptures happen below 6 centimeters.
So size is a major factor, but not the only one.
Exactly. Research has identified other independent risk factors besides diameter and pain.
Like what?
Things like the patient's age, having COPD or kidney problems, the extent of the aneurysm, and crucially, how quickly it's growing.
Expansion rate.
Right. The growth rate for descending thoracic aneurysms is actually pretty similar to abdominal aortic aneurysms, around 0.4 centimeters per year on average.
That's a useful comparison. Now, you mentioned the dilemma with TAAs, higher surgical risk than for aneurysms lower down. So how do surgeons decide when to treat?
It's a real balancing act. Given those higher surgical risks for TAAA repair compared to, say, infrarenal AAAs, the decision is tricky.
Is there a typical size threshold?
Most surgeons use a diameter of around 6 centimeters as a general threshold, but you have to weigh the natural history data, the rupture risk, against the potential surgical risks and the patient's long-term survival prospects.
And other factors come into play, too.
Definitely.
Yeah.
It's important to remember that studies show 40 to 50% of patients actually die from other causes before their aneurysm ruptures.
Right, so it's not just about the aneurysm itself.
Exactly. It makes the decision very nuanced. You have to consider the specific pathology, the patient's age, their other health conditions, and very importantly, their personal preferences and goals.
So a very individualized assessment. Are there other situations where surgery might be needed, even if the aneurysm isn't that big?
Yes. If there's also disease affecting the branch vessels narrowing or blockage causing mesenteric or renal ischemia.
Lack of blood flow to the gut or kidneys.
Right. Or if there are other aneurysms elsewhere, then treating a smaller TAAA might be warranted.
Okay. What about emergencies?
Absolutely. Acute events like plaque rupture inside the aorta, a mycotic infection, trauma, kidney failure because an inflammatory aneurysm is squashing the ureters, or malperfusion in an acute dissection, those all demand urgent repair even if the aorta isn't massively dilated.
Got it.
We also see complex cases involving the ascending aorta and arch plus the TAAA. Those often need staged repairs, which brings its own challenges.
And endovascular treatments, how do they fit in?
Yes. The rise of endovascular tech adds another layer. Sometimes open surgery is needed to fix problems from endovascular repairs or to treat aneurysm progression around existing endografts.
So they can interact.
Yes, and surgeons might even combine open and endovascular approaches sometimes.
It sounds incredibly complex, weighing all those factors.
Yeah.
Okay, once the decision to operate is made, what's the patient evaluation like?
It really starts with a very thorough evaluation. Cardiac, pulmonary, renal function, overall health vitality, really.
To see if they're fit for such a big operation.
Exactly. It's crucial for elective surgery. It's an involved process for patients and families, but vital for understanding the risks.
And imaging must be key.
Absolutely. Advanced imaging like MRI and CTA are the main tools. They show the extent of the aortic problem, the branch vessels, all critical for planning.
Better tech now than before.
Oh, yes. The resolution is so much better now. We can see tiny patent intercostal arteries, understand complex dissections, see the plaque morphology in detail.
I mean, you mentioned 4D MRA.
Yes, four-dimensional magnetic resonance angiography. It's exciting. It lets us measure anatomy and blood flow dynamics non-invasively.
Like flow speed and pressure.
Exactly. Velocities, flow rates, wall stress, pressure gradients. It gives a much deeper understanding of how treatment affects things and the complex flow in aneurysms and dissections.
That sounds like a powerful tool. Beyond the physical side, what about informed consent? This is high-risk surgery.
That's a really critical and difficult part of the process. Getting truly informed consent for these complex, high-risk operations for life-threatening diseases,
Right.
It's nuanced.
Needs to be realistic.
Absolutely. The patient needs a realistic grasp of the challenges the surgeon faces and what they will experience. Best case, worst case scenarios.
Including the big risks.
Paraplegia, stroke.
Yes, paraplegia, stroke, kidney failure requiring dialysis, potential need for prolonged ventilator support. It has to be a frank discussion about probabilities, uncertainties, and what life might be like if the outcome isn't a full return to pre-op function.
And age plays a role in that discussion. It does. As the patient gets older, both the surgeon and the patient should really become more selective about pursuing treatment. It's all about aligning potential outcomes with the patient's goals and quality of life expectations.
Right. Okay, decision made, patient evaluated. Let's dive into the surgery itself. You mentioned different approaches.
That's right. The surgical plan is highly individualized. It depends on the specific anatomy, the pathology, and it requires real adaptability from both the surgeon and the anesthesiologist.
So what are the main options?
Well, they range from simple cross-clamping, that's the core of Crawford's technique, often with adjuncts to protect kidneys and spinal cord.
Adjuncts, extra protective measures.
Exactly. Then there are assisted circulation techniques like atrial femoral or femoral bypass.
Like a heart-lung machine, but partial.
Sort of, yeah. And in some cases, hypothermic circulatory arrest or HCA.
Okay, let's break those down. Extracorporeal circulation, or AC. What's that involve?
The most common form we use is atrial-femoral bypass. It's a partial heart bypass.
How does it work?
Oxygenated blood is taken from the left atrium, or a pulmonary vein, sent to a pump, and then pumped back into a femoral artery.
So it bypasses the section being worked on.
Exactly. It provides retrograde perfusion, backward flow to the pelvic and visceral arteries while the surgeon is working on the proximal part. You can adjust the flow to maintain pressure above and below the clamp.
And it helps the heart.
Yes, it reduces the workload on the heart during that proximal clamping. But importantly, it still relies on the patient's own heart and lungs for oxygenation and brain circulation, and it doesn't need full systemic heparinization.
Okay, so it supports circulation. What about HCA, hypothermic circulatory arrest? That sounds pretty dramatic.
It is a more extreme measure. It requires complete cardiopulmonary bypass.
Whole heart-lung machine.
Yes, with specific cannulation sites, often femoral artery and vein, sometimes ascending aorta, and you need a drain in the left ventricle
Why?
to start the heart enlarging and prevent lung congestion during bypass. Then the patient is cooled way down,
How cold?
typically 16 to 18 degrees Celsius. Very cold. And then the circulation is completely stopped while the surgeon does the critical proximal anastomosis, sewing the top end of the graft.
Complete circulatory arrest.
Yes. After that's done, they restart perfusion to the brain through a sidearm on the graft while the rest of the aorta is fixed.
What are the pros and cons?
Well, HCA provides excellent organ protection during the occlusion time, but it's complex. Longer pump runs, higher risk of bleeding from coagulopathy.
Clotting problems.
Right, made worse by the big incision and the cold. It's a major physiological stress, so it tends to be used less frequently.
Okay, two very different approaches.
Ah.
You also mentioned other techniques without pumps.
Yes, things like distal aortic perfusion, selective mesenteric perfusion, these can be done without full pump support. Shunts, like the Gott shunt or axillofemoral bypass, have been used.
Passive bypass.
Essentially, yes. Dr. Cambria also described an inline mesenteric shunt to restore flow quickly, often combined with cold renal perfusion, though he apparently moved away from epidural cooling. Each technique has its pros and cons.
Sounds like surgeons have a toolbox then. What's your preferred approach, generally?
Our philosophy is really to tailor it to the patient. Anatomy, pathology, aiming to simplify where possible but maximize safety.
So, often the Crawford technique.
Mostly, yes. Simple cross-clamping is the core. But, and this is key, we incorporate several adjuncts that Crawford himself didn't use.
Right.
Systemic hypothermia, spinal fluid drainage, SFD, using steroids and endorphin receptor antagonists like naloxone, and really meticulous optimization of perfusion, pressure, MAP, and cardiac function.
So, enhancing the basic technique.
Exactly. We find these adjuncts crucial for protecting the spinal cord, kidneys, other organs. We only use HCA when the anatomy dictates it, like if proximal clamping is impossible or sometimes an acute dissection.
And this is based on research.
Heavily informed by experimental studies, yes. Ultimately, the research shows good outcomes are possible with any of these techniques as long as you diligently follow the experimentally proven principles of organ protection.
So the crucial insight isn't necessarily which technique, but how you apply the protective principles within that technique for that specific patient.
Precisely. It's about applying the science.
Okay. Now, anesthesia. This sounds incredibly demanding for the anesthesia team.
It is absolutely critical. The anesthesia for TAAA repair is highly complex. It requires continuous monitoring and control of multiple body systems.
What kind of monitoring?
Arterial lines, usually upper and lower body, pulmonary artery catheter for heart function, transesophageal echo, TEE, to watch the heart pump, EEG for brain activity.
Especially with the barbiturates.
Right, which we use to reduce the brain's oxygen need during clamping. We also track core and parochial temperatures closely, coagulation, blood chemistry, blood gases. It's intensive.
And the spinal drain.
Yes, in most patients, a lumbar spinal drain to monitor and control spinal fluid and pressure. Draining fluid aims to improve spinal cord blood flow during clamping.
And medications.
The anesthesiologist uses various drugs to control blood pressure, optimize heart function. Importantly, we avoid certain vasodilators like nitroprusside.
Why though?
Because studies show they can actually steal blood flow away from the spinal cord, not what you want.
Makes sense.
We routinely infuse sodium bicarbonate during clamping above the kidneys to counter acidosis. Our group also uses methylprednisolone, infuses naloxone during and after, and gives mannitol before and during occlusion and after reperfusion for kidney protection.
What about breathing? One lung ventilation.
Yes, sometimes needed for extensive proximal repairs. We prefer using an ARNT endobronchial blocker for that, easier and safer, we find, than a double lumen tube, and provides great lung isolation.
And temperature.
We use moderate systemic hypothermia, cooling to 31-34 degrees C, helps prolong tolerance to ischemia in the spinal cord and organs, and aggressive blood component replacement is vital to prevent coagulopathy.
So the anesthesiologists have a huge role during the different phases. What are their key jobs during exposure, for example?
During exposure, they focus on cooling the patient cool room, cool IV fluids. Then, right before clamping, they carefully drain spinal fluid to get the pressure below 6 millimeter Hg. That timing needs really close communication with the surgeon.
And if assisted circulation is used?
Then they make sure the patient is fully exposed before heparin is given to minimize bleeding, and extra prep, depending on where the cannulas go.
Okay. And during the reconstruction itself?
Their main goal is adequate resuscitation, replacing blood loss with salvaged blood, banked cells, plasma, optimizing oxygen delivery to tissues, maintaining volume, supporting the heart, keeping that MAP above 90 millimeter Hg.
While keeping spinal fluid pressure low.
Exactly. Without draining too much, it's a constant balancing act. If the anesthesiologist isn't proactive and aggressive in managing all this heart function, fluids, clotting, blood pressure, the patient's risk of complications skyrockets.
Complications like?
Coagulopathy, paraplegia, kidney failure, cardiac problems, even death. In these big aortic reconstructions, the anesthesiologist is truly as critical to success as the surgeon.
And adjustments needed for assisted circulation.
Yes, particularly with left heart bypass, you have to prevent relative hypotension above the clamp. Low pressure there reduces collateral flow to the spinal cord.
Especially without hypothermia.
Even more pronounced then, yes. Maintaining MAP above 90 requires aggressive fluids, maybe drugs, to support the heart and blood pressure. And this is crucial even during rewarming from HCA. You don't want low pressure undoing the benefits of the cold.
It's clear they're a vital partner. Okay, let's move to patient positioning. That must also be carefully planned.
Absolutely. For the standard thoracoabdominal incision, the patient is positioned on their side, lateral decubitus, left side up.
Why left side up?
That gives the best access to the descending thoracic and abdominal aorta through the left chest. Shoulders usually stay fairly vertical, but the pelvis is tilted back.
Why tilt the pelvis?
To get easy access to the left femoral artery and vein, in case you need to put in an arterial line, do cannulation for bypass, or maybe an aortofemoral bypass later. Sometimes you tilt it a lot to expose the right groin too.
And how do you keep them stable?
We use a special positioner, like an Olympic backpack, which molds to the patient, holding securely for what can be a long operation. Figure 79.4a shows it well.
Okay, specific positioning for optimal access. Now, the exposure itself. How do surgeons actually get to the aorta?
The incision level and extent depend entirely on which part of the aorta needs replacing.
So, different incisions for different aneurysms.
Exactly. If it's just the descending thoracic aorta, a simple thoracotomy incision between the ribs, maybe 4th to 7th space might be enough.
And for the thoracoabdominal ones?
For a Crawford type 3 or 4, involving the lower part, we can often use an extraperitoneal approach through the 8th or 9th intercostal space. Stay out of the main abdominal cavity.
But for the more extensive ones, type 1 or 2?
Then we usually need a higher incision, 5th or 6th space, and we do enter the abdomen. We have to mobilize the spleen, colon, left kidney over to the right side to expose the retroperitoneal space where the aorta sits.
That sounds like a lot of mobilizing.
It is, and to help with exposure and reduce rib fractures from the spreader, we often do something called posterior shingling of the ribs, especially with higher incisions.
Shingling.
Yeah, cutting them near the spine allows more retraction. Figures 79.4 and 79.5 show that. For these extensive repairs, we typically incise the diaphragm right through the aortic hiatus.
The opening where the aorta passes through.
Correct. That gives complete exposure from the descending thoracic aorta down to the iliacs if needed. You can see that in figure 79.5 and 79.6.
Are there alternative approaches to the diaphragm?
Some surgeons try to spare the central diaphragm or use 2 separate incisions, hoping to reduce lung problems. But that can obscure the view and hasn't shown a major benefit in reducing ventilation time.
So the extent dictates the exposure. What if the patient's had surgery before?
Ah, yes. Prior aortic or thoracic surgery makes exposure significantly harder. Scar tissue, inflammation, adhesions, especially lung adhesions to the chest wall.
Tedious to dissect.
Very tedious and carries a risk of lung injury, bleeding, air leaks.
What about exposing the branch arteries? Celiac. Mesenteric renals.
We typically dissect and expose the celiac, SMA, and left renal. But if the aneurysm is huge or inflammatory, mesenteric exposure can be too difficult and sometimes has to be skipped.
What if there's mesenteric ischemia?
Then you might need to expose the SMA more fully, dissecting anterior to the kidney. And sometimes you find anatomical variations, like a retroaortic left renal vein.
Vein behind the aortic.
Yes, needs careful handling, maybe even temporary division and reattachment later. Figure 79.6b shows that.
And nerves? Any risks there?
Definitely. Exposing the arch vessels, depending on where the proximal clamp goes, you have to be careful not to injure the phrenic nerve, vagus nerve, or its recurrent laryngeal branch.
Recurrent laryngeal. That affects the voice.
Yes. Patients need counseling beforehand about the risk. About 10% get vocal cord paralysis if the anastomosis is high up near the subclavian artery.
What else helps with arch exposure?
Dividing the ligamentum arteriosum often gives better access. And in emergencies, or with huge proximal aortas, we might open the pericardium for easier control.
Are there other particularly challenging scenarios?
Chronic dissections definitely add complexity. And unusual arch anatomy. Figure 79.7 shows a tricky case with an aneurysmal aberrant right subclavian artery in a dissected arch.
What do they do?
Had to do a staged procedure, a carotid subclavian transposition first, to fix the subclavian aneurysm and secure the arch for clamping later during the main TAAA repair.
Wow. Okay, what about exposing the iliac arteries down below?
Left iliac is usually easy. Right might require dividing the inferior mesenteric artery, IMA, at its origin to mobilize the distal aorta.
What if the IMA is important for colon blood supply?
If it's large and patent, it might need reattaching, but that's uncommon. The ureters, especially the left, are vulnerable too, particularly in inflammatory cases or redos. Sometimes preoperative stents help identify them.
So the key is anticipating problems.
Absolutely. Get complete enough exposure up front so you're not scrambling to dissect more once the aorta is clamped.
Right. That makes sense. Okay, aorta exposed. Let's talk repair. What's the first step after exposure? Clamping.
Yes, clamping. But first, heparin. The strategy depends on the technique.
How so?
With simple cross-clamping, usually just a heparin flush on the field. If there are previous grafts or we're clamping way up high near the head vessels, a small systemic dose.
And with assisted circulation or HCA?
Assisted circulation usually needs less heparin, monitored with ACTs. HCA needs a full systemic dose.
Okay, so heparin sorted. Then what determines when you clamp?
Once exposure is complete and we hit our targets, systolic pressure under 100, temperature below 34 degrees C, spinal fluid pressure below 6 millimeter Hg, and maybe barbiturate suppression if needed. Then we clamp and open the aneurysm.
And pressure during clamping?
We keep the mean arterial pressure, MAP, above 100 millimeter Hg during the clamp time.
What about back bleeding from intercostals?
If there are lots of open ones, or with assisted circulation, we might use distal or sequential clamping to control that.
Do you always reattach intercostals?
Not usually in descending thoracic aneurysm DTA repairs, but in TAA repairs, yes, we select some beforehand.
How do you select them?
Based on preoperative MRA, their location usually T8 to L2 and whether they look patent during surgery. We temporarily clamp maybe 2 to 4 of those.
And the rest?
The remaining intercostal and lumbar openings are quickly oversewn to minimize blood loss and maximize that collateral perfusion pressure.
What about the visceral and renal arteries?
We use Fogarty balloon catheters to block flow in those temporarily, then expose the renal artery openings.
And kidney protection.
Critical.
Yeah.
Each kidney is flushed with 300-400 milliliters of cold 4 degrees C renal perfusion solution. Contains mannitol, heparin.
Cold flush?
Yes. Provides hyperthermic protection and also helps lower core body temp further, maybe down to 31-32 degrees C.
Yeah.
Good for spinal cord and other organs too.
Does that affect spinal fluid pressure?
It can, yes. That rapid cold infusion can raise SFP, so the anesthesiologist might need to drain a bit more fluid.
Okay, a carefully controlled sequence. After clamping and opening, what's next? The graft itself.
Yes, the proximal anastomosis. Sewing the graft to the healthy aorta above the aneurysm.
What kind of suture?
Typically a strong 2-azoproline, but if the tissue is fragile dissection, bad calcium, thin wall, maybe finer sutures, or reinforcing with felt strips or pledgets.
Goal is a clean anastomosis first time.
Absolutely. You want to avoid repeated cross-clamping to fix leaks. Takes a bit more care initially, but saves time and trauma overall.
How do you check it?
Once it's sewn, put the patient head down Trendelenburg, clamp the graft itself after flushing out air or thrombus.
Critical to avoid stroke.
Very critical. Then briefly release the main aortic clamp. If there are leaks needing attention, usually fix them with a pledgeted stitch without reclamping the aorta.
Okay, top end secured. What about the vital branches, visceral and renal arteries? How are they reattached?
That's the next big step. Most commonly done using a Carroll patch technique.
Carroll patch.
Sewing a patch of the graft over the openings of multiple vessels. The configuration depends on how they're spaced.
Common patterns.
Often celiac, SMA, and right renal together, left renal separate, or celiac SMA together, both renal separate. Key is keeping the patch narrow to avoid future aneurysms.
What if they're far apart?
Attach them individually. Avoid one huge patch that's prone to dilating, especially if done by less experienced surgeons.
Are there alternatives to patches?
Yes. Individual bypass grafts, especially using branched grafts like Coselli's, that's often preferred in connective tissue disorders like Marfan, where patch aneurysms are more common.
What if the arteries are diseased, blocked with plaque?
Happens in about a third of patients. We often need to do an endarterectomy, clean out the plaque on some or all of those vessels.
Even if they've been stented before?
Yes. Usually remove the stent along with the plaque then.
Is endarterectomy always preferred?
Some surgeons prefer bypass or direct stenting due to potential dissection flaps beyond the endarterectomy. But a well-done endarterectomy generally has better long-term patency, so we prefer it. Bypass might be needed if endarterectomy fails, or the artery is aneurysmal or too far away.
What about dissections extending into these arteries?
Often, the flap can be excised to create one channel. Sometimes stenting the true lumen is needed.
Okay, once they're reattached, how do you restore flow?
Patient back in Trendelenburg, flush the graft again, then remove the Fogarty balloons blocking the vessels. Restore flow to the organs.
How do you check if it worked?
Give intravenous indigo carmine dye to see if the kidneys make blue urine. Feel pulses. Use a handheld Doppler. If any doubt, use intraoperative duplex ultrasound.
How long does this part take?
Average time for proximal anastomosis and restoring renal flow is maybe 47 minutes in our hands, but it can take over an hour. If it's prolonged, we repeat the cold renal flush.
Meticulous work. Okay, visceral and renal arteries reattached. What's next?
The distal anastomosis. Sewing the graft down to the distal aorta, usually at the iliac bifurcation.
Check for clots first.
Always. Check for back bleeding, flush the graft, then complete the anastomosis and restore flow to the legs.
What if the iliacs are aneurysmal too?
Then use a bifurcated graft, Y-shaped. Connect the top to the main graft, the legs to the iliacs. Same approach if they've had prior aortic surgery or endovascular repair down there.
Right, that completes the main aortic reconstruction. But you mentioned reimplanting intercostal arteries earlier. When does that happen?
Only after the entire main aortic reconstruction is finished.
Why so late?
To avoid prolonging the ischemia time to the organs, pelvis, and lower extremities during the main repair.
Okay, so which ones do you reimplant?
The ones we selected earlier, maybe 2 to 4, based on MRA or patency, usually T8L2.
How?
We use a button technique. Make a small hole in the side of the aortic graft and sew the intercostal artery button to it.
Does technique matter?
We think only techniques that maintain inline flow have a decent chance of staying open. End-on bypass grafts to these small arteries often fail, though, honestly, there isn't much solid data on long-term patency of reimplanted intercostals.
Do evoked potentials help select which ones, MEPs or SSEPs?
Some surgeons use them, but the evidence that MEPs improve outcomes over other selection criteria is limited. They might help monitor perfusion pressure adequacy, though.
Any downsides to monitoring?
Usually requires assisted circulation, which adds complexity and hasn't clearly shown reduced paralysis risk itself. Plus, MEP loss can happen from peripheral nerve ischemia with simple cross-clamp, confusing the picture.
So why reimplant them at all?
We tend to do it mainly in the most extensive aneurysms, primarily hoping to reduce the risk of delayed paraplegia.
Delayed, like after surgery.
Yes, if the patient has a hypotensive event, later sepsis, heart attack, bleeding, having those extra feeders might help.
But it's sequenced at the end.
Right. Overall goal is finishing the whole thing in 3 to 5 hours with minimal blood loss. Good technique, efficient work. Longer ops make it harder for anesthesia to keep things stable.
Okay, so intercostal reimplantation is selective, and its role is still debated. Now, aortic surgery has changed a lot with endovascular treatments like TVAR. How has that impacted open repair?
Hugely. TVAR, thoracic endovascular aortic repair, has really expanded the options for dissection, aneurysms, trauma.
Taken over some open surgery.
Definitely. For older patients, TVAR has largely replaced open surgery and even medical management for most problems just in the descending thoracic aorta.
But not for everyone.
Less so in younger patients with longer life expectancy. usually due to concerns about long-term durability of the endografts. Traumatic transection is an exception there.
Can open and endo work together?
Absolutely. They can complement each other. For example, TEVAR might treat an aneurysm that forms above a previous open repair.
Or staging procedures.
Exactly. We sometimes stage TAA repair, do TEVAR for part of it, then open repair for the rest. Can potentially lower the overall risk.
Any technical challenges combining them?
Sewing Dacron graft to an endograft can be tricky. Size mismatch sometimes requires modified techniques, like using felt.
What about in dissections?
TEVAR can sometimes simplify things later. By covering the entry tear, it might effectively turn a complex Crawford type 2 dissection into a less extensive type 4 for later open repair.
But endo isn't foolproof. Failures happen.
They do, and sometimes those failures require open surgery. We've seen Marfan patients, for example, who had a type A repair with a frozen elephant trunk. Then the aorta continued expanding, needing a complex open TAA repair later.
Any pitfalls when operating after endo?
A critical one. Never just clamp the endograft component itself distally. It can wind sock and pull away proximally. You lose control.
So what do you do?
You have to clamp the aortic wall with the endograft. And the anastomosis needs to include the aortic wall, which can be tough in big aneurysms. Often means clamping the proximal Dacron trunk and cutting or removing the endograft to get a stable connection.
So complex hybrid scenarios, but for straightforward descending thoracic aneurysms.
Now, usually treated with endografts if the anatomy is suitable, good landing zones.
And if open DTA repair is done, same principles apply.
Yes, same spinal cord protection principles as for TAA. Usually just a thoracotomy incision, unless it extends way down.
Intercostals reattached. Renal perfusion.
No, typically don't reattach intercostals in DTA repair, and direct renal perfusion isn't feasible. But the other adjuncts, SFD, hypothermia, steroids, mannitol, and naloxone are used, often without full assisted circulation.
Okay, so endo is huge now, but open surgery remains crucial, sometimes working alongside it. Once the surgery's done, what's the immediate post-op care like?
Patients typically go to the ICU for 2 to 4 days after open TAA repair, depending on how they're doing.
On a ventilator?
Initially, yes, until they're fully awake and breathing well independently. Could be hours for a type 4, maybe up to 2 days for an extensive type 2 if no complications.
And rewarming, you cool them down deliberately.
We let them rewarm gradually, no rapid rewarming devices. We continue spinal fluid drainage.
Keeping pressure below 6.
Right, until they're awake enough to check neurological function, leg movement. If they're okay, we just monitor pressure. Only drain more if weakness develops.
Main focus in ICU.
Optimizing heart function and hemodynamics, good fluid replacement, maybe inotropes to support the heart. Keep that MAP above 90 mm Hg for the first 48 hours, crucial for collateral spinal cord perfusion.
Other ongoing treatments.
Continue fresh frozen plasma and naloxone infusions for 48 hours. For pain relief, we prefer fentanyl over morphine.
Why avoid morphine?
Potential negative effects after spinal cord ischemia. For sedation, usually propofol.
Why propofol?
Easier to wake patients up quickly for neurochecks and ventilator weaning compared to benzodiazepines.
What about delayed paralysis? Can that happen?
It can, unfortunately. If a patient develops weakness later, we act fast.
How?
Increase MAP and cardiac output, drain more spinal fluid, restart the neuroprotective meds. Sometimes these deficits can be reversed with prompt intervention.
So, who's most at risk?
Patients who haven't established good collateral spinal cord flow after surgery, they're vulnerable if oxygen delivery drops, low heart function, low BP, hypoxia, anemia.
So meticulous monitoring and support are key. What about longer-term outcomes? How do we measure success now?
It's evolved. It's not just about mortality and morbidity anymore. We now focus much more on functional recovery and quality of life from the patient's perspective.
That's a really important shift. Now, one of the biggest fears you've mentioned is spinal cord ischemia leading to paralysis. Let's really dig into that.
Right, spinal cord ischemia causing paraplegia or paraparesis. It's been the most unpredictable and feared complication since the 1940s.
Adam's work in the 50s was key.
Absolutely groundbreaking. He linked the anatomical variations in the spinal cord's blood supply to neurological problems after surgery. He identified the greater radicular artery.
The artery of Adamkiewicz.
Yes, that one. Usually arises between T8 and L2. It supplies a vulnerable part of the lower thoracic cord where other feeders are sparse, and the main anterior spinal artery, ASA, running down the front, is smaller.
So that artery is critical.
Very important. And the ascending part of the ASA from it is small high-resistance limits, backward flow from shunts or bypass. There are also these weird muscular cushions associated with it, suggesting maybe neurochemical factors play a role too.
And the risk relates to how much aorta is replaced.
Proportional to the number of open intercostal arteries in the replaced segment. But it varies with pathology.
How so?
On average, about half the intercostals are already blocked by the disease itself, more so in degenerative aneurysms. This pruning actually encourages collateral vessel development.
Autocollateralization.
Exactly, which can reduce the ischemic risk during replacement.
So for decades, the focus was on reattaching those critical arteries.
Largely, yes, the anatomical paradigm. But it hasn't eliminated paralysis.
Why not?
Because, as studies show, spinal cord circulation during and after occlusion relies heavily on those collateral arteries. So, manipulating physiological factors.
Like blood pressure, oxygen delivery.
Exactly. Perfusion pressure in the collateral network, tissue oxygen delivery, the cord's tolerance to ischemia. Those turn out to be more effective strategies for preservation.
So the cause is anatomical, but the best protection is physiological.
That's the key insight, yes. The focus has shifted.
What are some of those key physiological protection measures then?
Well, the work by Itz and Griep on the coaxial collateral network concept is probably the most insightful research here.
What did they find?
In their pig model, blocking more intercostals caused a bigger initial drop in collateral pressure, but, and this is crucial, spinal cord blood flow and collateral pressure recover pretty quickly.
How quickly?
About 40% recovery in 24 hours, 80% in 72 hours, even with no intercostals left open.
Wow. So the body adapts.
It does. And the most important factors they found to optimize collateral perfusion and protect the cord until recovery happens are hypothermia,
Cooling.
spinal fluid drainage, keeping SFP low, high arterial perfusion pressure, MAP, maintaining tissue oxygen delivery, avoiding anemia, hypoxia, keeping cardiac output good, and neurochemical protection, naloxone, steroids, barbiturates.
Neurochemical, like blocking harmful chemicals.
Yeah, reducing elevated excitatory amino acid neurotransmitters, which naloxone helps with, and avoiding those stealing vasodilators like nitroprusside.
And applying these principles works.
Dramatically. We saw an 80–85% reduction in paralysis incidence. Observed to expected ratios dropped from 1 down to 0.15, 0.18 without relying on assisted circulation or routine intercostal reimplantation.
And others have seen similar results.
Yes, Dr. Beck saw similar declines using these protocols with complex branched endografts. It's clinically validated.
So managing physiology is key. You mentioned an expected paralysis model. What's that?
To analyze outcomes better, we developed a mathematical model. It calculates the expected risk of paraplegia based on how much aorta is replaced and the clinical situation acute dissection.
Based on older data, before adjuncts.
Exactly, based on Crawford's results without neuroprotective adjuncts. The formula considers Crawford type, acute presentation, dissection.
And it works.
It's been validated on over 5,000 patients, accounts for over 98% of the variability in paralysis rates between different studies. It lets us calculate an observed to expected, or OE, ratio.
Better than just percent paralysis.
Much better. Percent paralysis doesn't account for case mix variation. OE ratios let us compare strategies more accurately.
And what has analyzing 15,000 patients with this model shown?
A significant decline in overall paraplegia rates, about 75%, mostly since 1997, the modern era.
Era 2.
Era 2, yeah. Marked by that shift from the anatomical focus to physiological neuroprotection, SFD, hypothermia, high MAP, neurochemicals.
What about assisted circulation alone? Did that help?
Experimental studies didn't really support it for paralysis prevention alone. Didn't reliably improve lower spinal cord blood flow.
Other risk factors.
We noted epidural analgesia or neuraxial narcotics post-op might potentially increase risk. The model confirms extent and dissection matter relates to at-risk intercostals, and physiological instability in acute cases is important too.
Any other factors stand out?
Cardiac function. Our multivariate analysis showed cardiac index, how well the heart pumps for the patient's size was statistically more important than age in protecting against paraplegia.
Why? Better collateral perfusion?
Likely. A stronger pump pushes blood through those collaterals more effectively. Might explain why older patients, who often have weaker hearts, are at higher risk.
Okay, so the model confirms physiology matters. What does it tell us about specific protection measures?
Well, it aligns with our experience. Analysis of 5,000 plus patients showed simple cross-clamp and assisted circulation without adjuncts had similar OE ratios, around 1, basically matching expected rates.
But adding adjuncts changed things.
Dramatically. Adding spinal fluid drainage, SFD, to either technique dropped the OE to 0.4, 0.5. Then, in era 2, adding hypothermia and increased MAP along with SFD dropped it further to a mean around 0.25.
So if you optimize those things,
The outcomes for paraplegia seem independent of the repair technique XCL, AC, or HCA. The OE ratios become equivalent.
why do results still vary then?
The variation within techniques probably reflects how consistently and aggressively those protective strategies are applied. Might explain poorer outcomes sometimes seen in smaller centers.
Can you give an example?
Look at 2 randomized trials of SFD from the same place, a decade apart. Crawford's early one showed no benefit, but they didn't control SFP well, just removed a fixed amount and used nitroprusside.
Which steals flow.
Right. Coselli's later trial did control SFP, used hypothermia, increased MAP, and did show a significant protective effect from SFD, with OE dropping to 0.22.
So comprehensive physiological protection is key, more than the technique itself. What about evoked potentials and intercostal reimplantation now?
Evoked potentials, SSEPs and MEPs, have definitely helped understand the link between MAP and spinal cord function and the potential role of reimplantation.
What has they shown?
Group and Jacobs showed MEP loss during clamping can often be reversed just by raising MAP to 100, but they differed on reimplantation.
How so?
Creep, with a very low OE of 0.14, found no clear benefit or need for routine reimplantation. Jacobs, OE 0.25, felt MEPs were needed to select arteries for reimplantation.
What's your approach, Ben?
Since 2005, we've reimplanted selected intercostals, T8L2, identified by MRA or patency, mainly hoping to reduce delayed paraplegia from later hypertensive events.
And the result?
A modest overall decline in OE from 0.18 to 0.11, most noticeable in extensive type 2s, where it dropped from 0.34 to 0.18.
So what's the bottom line?
Based on our experience in GREETs, it seems reimplantation might play a role in the most extensive cases, but it's likely not the most critical factor. Prolonging ischemic tolerance and maximizing collateral flow seem more important.
Okay. And these principles apply to descending thoracic aneurysms too?
Yes, same principles for open DTA repair, though modern open series are fewer now because of TVAR.
What does the series show?
Safi and Coselli reported large series with comparable results. Coselli compared XCL and AC, found no statistical difference in paraplegia risk, around 2–4%, low mortality. Safi reported similar rates, mostly using AC plus SFD.
And your experience?
With XCL plus SFD for open DTA, we've had very low paraplegia, OE 0.11, and reasonable mortality, especially elective.
So protection works there too. Okay, let's shift to another major issue. Pulmonary complications.
Yes, lung problems, prolonged ventilation, pneumonia, respiratory failure are the most common complications after open TAAA repair, up to 27% of patients.
That's high.
It is, and 8–10% might need a tracheostomy. Tragically, about half of those eventually die from respiratory failure.
Why so common?
Largely because the patient population often has underlying lung issues. Around 80% are current or former smokers, 40% have COPD. Limited baseline function and reserve.
Other contributing factors.
Age, osteoporosis, chronic kidney disease, heart failure, they all contribute to weaker respiratory muscles, reduced breathing capacity. And that loss of strength correlates with mortality risk in the elderly.
And the surgery itself impacts the lungs.
Big time. The incision itself reduces lung function post-op. Recovery takes 10–30 days.
Yeah.
And the higher the incision,
The harder to wean from the ventilator.
Exactly. 8th space or lower, often extubated in hours. 5th space for a type 2 might need 2–4 days even without complications.
Anything help?
Routine CPAP, good pain control can improve function, maybe shorten intubation time, but post-op lung problems are a major driver of long hospital stays and increase the effect of age on mortality risk.
Could pre-op strengthening help?
Possibly. Improving muscle strength and functional capacity beforehand might reduce risk. Worth exploring.
Okay. Critical role of lung health. Let's talk overall mortality. What are the numbers and trends?
In our database, 15,000 patients, 86 reports average mortality is 9.3%, but a huge range, 4% to over 37%.
It's hard to compare directly.
Yes, because reports mix elective and acute cases. So we developed a mortality model, too.
What does it consider?
Whether it was acute and the predicted paraplegia risk. It accounts for about 86% of the variation in reported mortality rates.
What does it show?
Basically quantifies what we know. Acute cases and patients who develop paraplegia have the highest risk, either catastrophic events or lack of physiological reserve, especially respiratory failure. Bleeding causing shock is another factor.
And acute patients are higher risk. Why?
Unstable condition, obviously, but also no time for screening and optimizing comorbidities.
How does age factor in?
Big effect. Elective mortality in our data. 0% under 60, up to nearly 6% for selected over 80s. Acute mortality jumps from under 2%, 60, to nearly 43%, 80, and hits 67% for acute over 80s with bad kidneys.
But overall mortality is improving.
Yes, significant decline reported over the last 25 years. Era 1 mean OE was 1.46, Era 2 is 0.72.
Why the improvement?
Reduced paraplegia accounts for almost half, 43%. Paraplegia carries a high mortality risk itself, 27% overall, higher with age.
And the rest?
Likely factors like better centralization of care in high-volume centers in Era 2. Maybe patient selection, though hard to quantify.
So, still risky, but improving. You've mentioned renal function several times. Let's focus on that.
Poor kidney function is a major red flag, associated with more complications, more paraplegia, higher mortality.
That's a marker of overall health.
Exactly. Often reflects a less robust patient, more advanced comorbidities, less reserve. And post-op kidney failure needing dialysis, that carries a 50–60% mortality risk. Preserving function is crucial for long-term survival.
What predicts mortality most often?
In most studies, age and baseline kidney function are top risk factors.
How effective are strategies to protect the kidneys during surgery?
Interestingly, just perfusing them with warm blood during bypass hasn't been great. Dialysis rates still up to 15% sometimes.
Why not effective?
Normothermia doesn't prolong ischemic tolerance enough, and perfusion pressure is often too low, especially in diseased kidneys.
What does work?
Cold. Perfusing at higher pressures with moderate or deep hypothermia, either HCA or cold renal flush, 20 degrees C, seems much better. Dialysis rates drop to 3% or less in most reports using cold blood or crystalloid.
And your experience?
Matches that. Our strategy and Lemaire's of rapid cold flush, 4 degrees C solution, result in low permanent dialysis rates, around 0.8% for us, with most temporary dialysis patients recovering function in a couple of weeks.
So keeping kidneys cold is key. Okay, bringing it together, does surgical technique itself affect overall morbidity?
As we said, better understanding of injury protection mechanisms is what improves results. It needs a team approach, evidence-based protocols.
But the debate continues. XCL versus AC versus HCA.
It does. But the data suggests equivalent results are possible with any of them if those supported protection principles are followed. Anatomy physiology might dictate the choice sometimes.
Quick recap of pros cons.
XCL plus SFD, simpler, faster, less hypotension risk, no heparin, quicker overall, but harder anesthesia, cardiac strain hypertension. AC plus SFD reduces cardiac strain, but risk of hypotension, more bleeding, heparin, more complex setup. HCA, most complex, time-consuming, cooling warming, highest bleeding risk, coagulopathy, cold, full heparin, but excellent organ protection during ischemia.
How do you compare total morbidity across techniques?
We looked at observed paralysis plus deaths, divided by expected for models, and overall morbidity OE ratio. Total morbidity was comparable between techniques, but showed a significant decline from Era 1 to Era 2 in all categories.
So again, applying protection principles is the main driver of improvement, regardless of technique. Finally, what about long-term survival and quality of life?
Relatively few studies look really long-term, even fewer at quality of life.
What do we know?
Significant mortality risk in the first year. COPD, paraplegia, renal failure often contribute. After year 1, survival improves but remains lower than the general population across all ages. Cancer becomes a big factor in the first 5 years.
Your experience matches that.
Yes, steeper early mortality, then gradual decline, higher long-term mortality across age groups.
The quality of life.
Studies suggest after the first year, scores are similar to age-matched populations, though older TAAA patients often report less stamina.
So most get back to pre-op quality of life.
Roughly 80%, yes. And it's a big but major complications severely reduce both quality and length of life.
So major surgeries, significant long-term implications, even for survivors.
Yeah.
Well, this has been an incredibly detailed and really insightful deep dive into open surgical treatment for these complex aneurysms.
It really has. We've covered a lot of ground, from the historical evolution to that crucial shift from just anatomy to embracing physiological principles, especially for spinal cord protection. But clearly, challenges remain: morbidity, mortality, long-term quality of life. There's still work to do.
And for you, the listener, we hope this discussion has given you a clearer perspective on just how complex this area of vascular surgery is, but also the amazing advancements that have been made. It's really a testament to medical ingenuity.
Absolutely. And considering all the progress we've talked about, it makes you wonder, doesn't it, what's next?
What future innovations hold the most promise?
Exactly. Maybe an early detection, less invasive techniques, or perhaps more personalized risk assessment. what will really push the needle further for improving outcomes and quality of life for people facing these devastating aneurysms.
A powerful thought to leave everyone with. If you want to explore further, the references mentioned throughout the source material, Adams, Crawford, Svensson, Acher, Etz, Caselli, Lemaire, Wynn, offer much deeper dives into specific aspects. Thank you for joining us for this deep dive.